Good afternoon, dear guys. Today we are here to discuss about the Mahotsav Scholarship 2.0 anatomy test. We had tests in two variants, first and second variant. Both variants were having 30 questions. And for your information, both variants have the same questions, only the sequence was different. So today we will be discussing all those 30 questions in anatomy. Okay, so today we are discussing the anatomy test for Mahotsav Scholarship 2.0. So the first question was, so today I am discussing mainly the sequence of question in first variant. Okay, so the first question in the first variant was, which artery is used for the arteriovenous shunting in with great saphenous vein for hemodialysis. Okay, and it is located behind the medial malleolus and 2.5 centimeter in front of teno-calcaneus. So here I have brought one image, you can see here, this is our medial malleolus and this is that tendon they are talking about, this teno-calcaneus tendon, and the artery you can see, this is our flexor retinaculum, and below the flexor retinaculum the artery mainly present is posterior tibial artery. So the correct answer is posterior tibial artery. Why not anterior tibial artery? Because anterior tibial artery is the branch of running in anterior compartment of leg. Okay, it is present in front of medial malleolus, not behind the medial malleolus. Peroneal artery, it is also known as fibular artery. Okay, if you know fibular artery or peroneal artery, these are the arteries of lateral compartment of leg. Okay, so this will also not be the correct answer. Last one was the circumflex fibular artery. Why not circumflex fibular artery? Because this is the smaller branch or is a small artery which is the branch of anterior tibial artery. So that's why this is also not the correct answer. So correct answer will be posterior tibial artery. Okay. Next, along with this you need to remember in hemodialysis we are making AV fistulas. We are connecting arteries with veins, or this is also called as AV fistula or AV shunting. For this, in the upper limb we are using mainly two arteries. One is the radial artery, other one is brachial artery. Okay. In the lower limb we are mainly using the posterior tibial artery because it is suitable for that site, it is easily to assess. So for all those reasons, in the lower limb, the correct in this question also, and in lower limb we are using posterior tibial artery. So the correct answer is posterior tibial artery. Next we will come to the second question. Second question was, the spinal sensory nucleus of trigeminal nerve has second order neurons to carry which sensation? Okay. So if you know trigeminal nerve nerve is a cranial nerve which is of fifth number. If you know, this nerve is divided into, or it is a mixed nerve. Mixed nerve means it has both sensory fibers and motor fibers. The sensory fibers is mainly from the face and the motor fiber is for chewing muscles or muscles of mastication. Okay, so this is the mixed artery or mixed nerve, mixed cranial nerve. Okay, this sensory fibers again divide into three parts. So this fifth cranial nerve is having three parts, V1, V2 and V3 part. Okay, V1 is also known as ophthalmic part, V2 is also known as maxillary part, and V3 is also known as mandibular part. If I will ask you from which this V1 part is passes in which cranial fossa, it is passes from superior oblique fissure. Maxillary nerve or V2 part of trigeminal nerve is passes from foramen rotundum. And in the third part, V3 part or mandibular is passes from foramen ovale. Okay. Next, if you know, for every nerve we need to remember their first order neuron, second order neuron and like that. Okay. So the first order neuron for this V1 part, V2 part and V3 part we need to remember. So for the first order neuron, the cell bodies of first order neuron of V1, the cell bodies are present in trigeminal ganglion. This trigeminal ganglion is also known as Gasserian ganglion. Okay. Second or V2 part have cell bodies in trigeminal ganglion, same because trigeminal nerve, and third part is also having cell bodies in trigeminal ganglion. Okay, so this is about first order neuron. All these are carrying sensation from face and they are giving this sensation to brain stem. Okay, so just before entering into the brain stem, they are having second order neurons. Okay, so now these second order neurons have different types of these second order neurons are divided into multiples. Like if it is mainly the sensory, then the trigeminal nerve, if you know, it is having three nucleus. First nucleus is motor nucleus, which is giving motor sensations. Two sensory nucleus is, first one is principal sensory or main sensory, and second is, and the second sensory or the third nucleus of trigeminal is spinal sensory nucleus. So these three nucleus are for trigeminal nerve. So these second order neuron for sensory fibers, either they can go into principal or main sensory nucleus, or they can go into the spinal sensory nucleus. Okay, so in this you need to remember this principal sensory nucleus receiving fibers from all parts V1, V2 and V3. So all these parts of trigeminal nerve giving their neuron to principal sensory nucleus. Okay, this nucleus is mainly present in pons. Okay, and it has second order neuron for 2-point discrimination of face and proprioception. So it is having two main sensation of face, which is 2-point discrimination and proprioception. Spinal nucleus, it is mainly present in medulla. Okay, and it is receiving fibers from B2 and B3, maxillary and mandibular nerve or mandibular part of trigeminal nerve, and it is having second order neuron for pain and temperature. Okay, so in the question they have asked us about spinal sensory nucleus of trigeminal nerve has second order neuron to carry which sensation, then the answer will be pain. Okay, so pain and temperature will go to the spinal sensory nucleus, proprioception, 2-point discrimination and vibration will go to principal sensory nucleus. Okay, so this is the correct answer for question number 2. Now we will come to the third question. Third question was, which of the following structures passing in between the superior constrictor and middle constrictor muscles. Okay, so in the pharynx we have three main constrictor muscles: superior constrictor, middle constrictor, inferior constrictor. In between them some structures are passing, so we need to remember all those areas and the structure passing. Okay, so the first area between the skull base and superior constrictor, second is between superior and middle constrictor, third we need to remember for between middle and inferior constrictor, and fourth between inferior constrictor and esophagus. So all those structure which are passes in between all these areas we need to remember. So the first structure in between skull base and superior constrictor muscle, the area or this area is known as sinus of Morgagni. Okay, so here I have added one table. So here you can see between base of skull and upper concave border of superior constrictor, which is also known as sinus of Morgagni. Here you can see this is base of skull and this is our superior constrictor muscle. In between these structures are passing. So which structures are passing? First is auditory tube or Eustachian tube, second is levator palatii muscle, third one is ascending palatine artery, Fourth one is palatine branch of ascending pharyngeal artery. So all those structure which are passes from sinus of Morgagni are auditory tube, levator belly palatini muscle, ascending palatine artery, palatine branch of ascending pharyngeal artery. So this is for sinus of Morgagni. Second one, the structure passes between superior and middle constrictor. This is stylopharyngeus muscle and glossopharyngeal nerve. Okay. The structures between inferior and middle and inferior constrictor, the structure which are passes through are internal laryngeal nerve and superior laryngeal vessels. The structure between lower border of inferior constrictor and esophagus, or this area is called as in tracheoesophageal group. The structure passes are recurrent laryngeal nerve and inferior laryngeal vessels. Okay. So in this question they have asked us about this structure passes between superior constrictor and middle constrictor, then our answer will be glossopharyngeal and nerve and stylopharyngeus muscles. Okay. So why not recurrent laryngeal nerve and inferior thyroid vessel? Because this is between inferior constrictor and esophagus. This internal laryngeal nerve and superior laryngeal, this is between middle and inferior constrictor. These structures passes between these two. Auditory and this levator palatini, this is in sinus of Morgagni. So that's why the correct answer is fourth one, that is glossopharyngeal and stylopharyngeus muscle. Next is, which of the following muscles are supplied by superior gluteal nerve? Okay. So for superior gluteal nerve you need to remember about few things, like if any injury happens to superior gluteal nerve, what will happen, and from where it has arises, what is the root value. Okay. So this superior gluteal nerve, it arises from dorsal branch of, okay, so arises from dorsal branch is of L4, L5 and S1. Okay. So the root value will be L4, L5 and S1. Okay. Then what is the course? It arises, then it leaves the pelvic cavity. Okay. It leaves the pelvis via the greater sciatic foramen. Okay. Via the greater sciatic foramen just above the piriformis muscle. Okay. So this is its course. Now supplies. It supply mainly three muscles. One is gluteus medius, other one is gluteus minimus, and third one is tensor fascia lata. All these three muscles are supplied by superior gluteal nerve. Above two muscles, this medius, gluteus medius and minimus, these are also the abductors of hip. Okay. So these will stabilize the hip during the walking. Okay. So whenever we are walking, our hip is stabilized by these two main muscles, gluteus medius and gluteus minimus. So here they have asked which of these muscles are supplied by superior gluteal nerve. So the answer will be gluteus medius, gluteus minimus and tensor fascia lata. So correct answer will be 1, 2, 3. What about piriformis? This piriformis is supplied by the nerve to piriformis majorly. Okay. Sometimes it can also supplied by superior gluteal nerve, but mainly it is supplied by nerve to piriformis, and which has S1 and S2 rami. Okay. This is also dorsal division, and from S1 S2 rami. Next is, suppose if somebody got injury of superior gluteal nerve. Okay. So if any injury to gluteus medius or minimus, okay, or any injury to superior gluteal nerve, or fracture of neck of femur, or fracture of greater trochanter. Why? All these injuries will lead to a common condition known as positive Friedland Berg sign. Okay. Or I can say lurching gait. Okay, so in all these conditions, a common pathology will be, or common sign will be, Trendelenburg sign will be positive, or patient will be having lurching gait. Okay, so gluteus medius and minimus, because these are the main abductors of hip. If they will not work properly, the during walking hip will not stabilize properly, and patient will have Trendelenburg sign positive plus lurching gait. Second, superior gluteal nerve, if it is not proper, these muscles are paralyzed, and again same condition. Neck of femur fracture also same, and greater trochanter fracture also will be same. Why? Because these muscles are inserting over the greater trochanter, so that's why the condition will be same. So here you can see the normal stabilization of hip during the walking, but here you can see positive Trendelenburg. Positive Trendelenburg means whenever patient is walking, the opposite side of the pelvis drops. Okay, so for this Trendelenburg sign, you need to remember dolly. Dolly means this drop in opposite side, drop on opposite side, and lurching on the same side, or ipsilateral. Okay, why I am saying this dolly is important? Because they will give you right nerve is injured, then they will ask you on which side you will find this Trendelenburg sign positive. If right is injured, then left side sign will be positive, but if they will ask you which side this lurching gait will be positive, then the right side that gait will be seen. Okay, so this is how we can identify our injury. So here the answer will be C, 1, 2, 3, because it supplies mainly gluteus medius, gluteus minimus, and tensor fascia lata. Okay, 5-year-old male presented with symptoms of inability to flex the distal interphalangeal joint of 4th and 5th digit. He was also not able to hold a piece of paper between his finger. What is the likely site of injury? Okay, so we have to tell the site of injury. Before telling the site of injury, we need to understand which muscle is injured, then only we can say which area is involved. Okay, so they have given us 4th and 5th digit, flexion is not proper, means he is not able to flex them. Okay, then he is not able to hold a piece of paper in between his finger, means card test is positive. Okay, both of these will indicate that the common nerve is injured here is ulnar nerve. So the ulnar nerve is injured here. Okay, if you know, or you can see here, this is our humerus. In humerus, if any injury into the neck, then mostly which nerve is injured? Axillary nerve. Okay, then if any injury into the radial groove or shaft, mainly the radial nerve is injured. But if they will ask you at which area ulnar nerve is passing, it is mainly passing into the lateral epicondyle. Okay, oh, not lateral, medial epicondyle. Okay, so it passes behind the medial epicondyle. So any injury into this area will lead to the ulnar nerve injury. So the answer will be medial epicondyle of humerus. Okay, ulnar nerve will supply flexor carpi ulnaris muscle. It will supply medial half of flexor digitorum profundus, hypothenar muscles, and it will also give sensory sensation to medial 1.5 finger or digit. Okay, and also it will supply all intrinsic muscles of hand except first and 2 lumbricals and thenar muscles. Okay, so all the muscles of hand are supplied by ulnar nerve except first and 2 lumbricals and thenar muscles. Okay, so that's why the correct answer here will be medial epicondyle. If they will ask us lateral epicondyle, then the nerve injury will be radial nerve, because it passes laterally. Radial groove, again radial nerve. If neck of humerus, then the answer will be axillary nerve. Okay, if axillary nerve injury, then mainly the deltoid will be affected. If radial nerve is injured, then the like wrist drop and finger drop, all those will be the symptoms. But here we have seen only 4th and 5th digit is affected, means specific area, means the ulnar nerve is injured. Next question is, which of the following muscle form the pelvic diaphragm? Okay, so for this you need to remember pelvic diaphragm is formed by few muscles, like first one is levator, any muscle. second is coccygeus muscle, third one is obturator internus muscle and fourth one is piriformis muscle. Okay, all these muscles are forming pelvic diaphragm. So here we have to check which muscle is there. So since here levator ani is not given, so you need to remember levator ani has comprised or composed of three parts: puborectalis, pubococcygeus and iliococcygeus. So levator ani is made up of these muscles. Okay, so here answer we will check. Iliococcygeus is correct, it will involve in pelvic diaphragm. Pubococcygeus is correct, it is also involved. Obturator internus is also involved. Only this deep transverse perineum, it is not involved in the formation of or not the muscle of pelvic diaphragm. It is mainly present in deep perineal pouch. Okay, so we will check first two, 1 to 4. Okay, so the correct answer will be 1, 2. A will be the correct answer. Here you can see the diagram. So this is puborectalis, this is our pubococcygeus and iliococcygeus. All three are forming levator ani. Okay, here we have coccygeus. This obturator internus mainly present in the lateral walls of ischioanal fossa. Okay, so this is about 6th, 7th question. Anterior relation of third part of duodenum are all except. Okay, so now they are asking us about the anterior relation of third part of duodenum. If you know, it is the horizontal part of the duodenum. Okay, so here you can see this is second part of duodenum, this is third part and this is the fourth part of duodenum. Okay, so in anterior relation, superior mesenteric vessel is present. Yes, it is present. Loops of duodenum, yes, it is related. Root of mesentery, yes. No relation with fundus or body of gallbladder because it is present more above than this. So if you want to remember, I will tell you all the relation of third part of duodenum. So posteriorly it is related to with which structure? So it is related to the right ureter, right psoas major muscle, right gonadal vessels, abdominal aorta, inferior vena cava. Okay, all these. Anteriorly it is related to loops of duodenum because duodenum is present just below this. So loops of duodenum, root of mesentery, and in this root of mesentery the superior mesenteric vessels are present. So these are also related to anterior relation of third part of duodenum. Then next is superiorly it is related to, if you know, this is here we have pancreas. So it is related to pancreas or head of pancreas. Okay, and inferiorly it is related to loops of duodenum. Okay, so these are all the relations of third part of duodenum. So here you can see, here we have pancreas. So third part superiorly related to head of pancreas. Anteriorly you can see this is root of mesentery. Inside this we have these vessels, superior mesenteric. So these are also related to these are also the anterior relation of third part of duodenum and duodenum's loop of duodenum. Posteriorly you can see this is third part. Okay, so in the third part right side it is related to the ureter, IVC, aorta and right psoas major muscle, right ureter, right gonadal vessels, abdominal aorta. All these are related posteriorly to third part of duodenum. So here correct answer will be fundus and body of gallbladder because they are asking except, means which is not correct answer. 7th is arrange the following afferent column in floor of fourth ventricle from medial to lateral. Okay, so this is a like factual question you have to remember. So here I have shown the section. So most medially we have somatic efferents, then we have spatial visceral efferents. Okay, then we have general visceral efferents, then we have general visceral afferents, special visceral afferents, general somatic afferents and special somatic afferents. So you can remember the full sequence from medial to lateral. Okay, so general somatic efferent, then we have special visceral efferent fibers or nucleus, then we have general visceral efferent fibers, then we have general visceral afferent fibers, then general special visceral afferent, then special visceral afferent, then general somatic afferent and special somatic afferents. So this is the correct sequence. So if you will check medial to lateral, general somatic will be later. Okay, so here we will arrange in them in sequence. So general somatic, general visceral, special somatic, special visceral. So general visceral will be in the first position or most medially. Okay, then we will have special visceral, this will be in the next lateral, then general somatic will be in the third position and special somatic will be most laterally. So correct answer will be 2, then 4, 1, 3. So correct answer will be B, 2, 4, 1, 3. Okay, so you have to remember this. Next 9 question is, all of the following are true regarding the anatomy of adrenal glands except. So for the anatomy of adrenal glands you need to remember all those their relations and everything. Okay, so here they are asking true except means the wrong one. Okay, so first, right adrenal gland is semilunar shape. No, this is incorrect. Why? Because right adrenal is pyramidal or triangular. Left adrenal is semilunar shape. Okay, so the correct answer will be A. But why not others? The left adrenal gland is closely related to tail of pancreas and spleen. Correct, because left side we have spleen and pancreas. Okay, so this is the correct answer. Correct statement. Adrenal gland is yellow in cross. This is also correct statement. These both are retroperitoneal. That is also correct. Okay. So here I have shown you all those relations of adrenal glands, like right adrenal gland mainly related to the liver, left will be related to stomach and spleen and tail of pancreas, and then inferiorly they will related to right will be related to right kidney, left will be related to left kidney, and they will related medially to celiac ganglion. Okay, all those things. Okay, so here correct answer will be semilunar in shape, because right is not semilunar, right is pyramidal or triangular, left is semilunar in shape. Next is 10th question. The fibers of internal oblique muscle and transverse abdominis muscle contribute to which boundaries of inguinal canal? Okay, so for this we need to know what are the boundaries of inguinal canal. Okay, so for that we have to know inguinal canal. So boundaries of inguinal canal. First I am writing it, then I will show you in diagram. So anterior wall we have, then we have roof, then we have floor, and then we have posterior wall. Okay, so anterior wall is mainly skin, superficial fascia and external oblique muscles aponeurosis. Okay, so here the specific is external oblique muscles aponeurosis. Roof, it is formed by the arched fiber. Okay, arched fiber which are coming from abdomen. The muscles will be internal oblique muscle fiber and transversus abdominis muscles arched fiber which are reflecting. Okay, so they will form the roof of inguinal canal. Floor is mainly formed by inguinal ligament, or inguinal ligament is also known as Paupert's ligament. Okay, and medial part of floor or medial end of floor is also have some part of lacunar ligament. Okay, so medial end of floor is also formed by lacunar ligament. Posterior wall is formed by transversalis fascia and conjoint tendon medially. Okay, so these are the main boundaries of inguinal canal. Now I will come to the diagram. Okay, so superficial ring means anteriorly, deep means it is posteriorly present. So from anterior to posterior if we are going, you can see here anteriorly external oblique muscle aponeurosis, before that we have superficial fascia and skin. So anterior wall is formed by skin, superficial fascia and external oblique aponeurosis. Okay, then posteriorly, posterior wall is made up of fascia transversalis and fascia transversalis along with this conjoint tendon. Okay, so along with conjoint tendon. Roof is formed by arched fiber of internal oblique and transverse abdominis muscle, and floor is formed by inguinal canal. Along with this, you also have to remember where we have deep ring opening and where we have superficial inguinal ring. Okay, so deep ring is in oval opening in fascia transversalis and deep ring is a triangular opening in external oblique aponeurosis. Okay, so this is our inguinal canal. So now they have asked boundaries. So anterior wall, they have asked internal oblique muscle and transversus abdominis muscle contribute to which boundaries of inguinal canal. So internal oblique muscle and transversus abdominis muscle, they have role in roof and they have role in posterior wall. Here I have told you internal oblique and transversalis abdominis and transversalis fascia. So correct answer will be 2 and 4. Okay, so correct answer is 2 and 4. They help in the formation of boundaries of inguinal canal in roof and in posterior wall. Here is the detailed diagram of inguinal canal relation, you can check. Next is all of the following is true about sacrococcygeal teratoma except. Okay, so you have to again check for the incorrect answer. Okay, so sacrococcygeal teratoma. Okay, if you know teratoma are those tumors which are arising from more than 2 germ layers, means they are arises from ectoderm, endoderm and mesoderm. They have all those contents. So all teratomas are benign. Okay, so I can say all mature teratomas are benign except those immature teratoma, means few teratomas are malignant. So all those teratomas which are mature, those are benign, and few can be immature which are malignant. So this is correct statement. Okay, second, it contains skin, cartilage, bone. Yes, because skin is from the ectoderm, cartilage, bone is from the mesoderm. So this is also correct. Next is it occurs due to defective migration of primordial cells to genital ridge. Yes, correct. Okay, if they will change genital ridge to the oropharynx, then this will convert it into oropharyngeal teratoma. Okay, so this teratoma or sacrococcygeal teratoma or oropharyngeal teratoma is mainly because of defective migration of primordial cells. So the correct answer in this question will be it occurs due to persistence of precaudal plate, which is incorrect. Why? Because it is not because of persistence of this precaudal plate, it is because of persistence of pluripotent cells of primitive streak. Pluripotent cells of primitive streak which are mainly derived from the epiblast. Okay, so that's why this is the incorrect answer. Okay, so the correct, so in this question where they are asking the which all of the following is true about sacrococcygeal teratoma except, means the correct, means we have to find the incorrect answer, and incorrect answer will be which is incorrect statement for this sacrococcygeal teratoma is persistent of precaudal plate. Well, 12th question, it is on neurological examination. A patient is not able to identify an object but is able to recognize the object from its texture and color and pattern. What is the likely defect? Where is the likely defect? So when we are not visually identifying any object, but we can recognize the same object from its texture, color, pattern, this condition is known as agnosia. Okay, so inability to identify object visually but identifiable by all these, this is called as agnosia. This agnosia is of two types. It can be apperceptive or it can be associative. Okay, apperceptive means image is totally distorted, means image is not properly forming, that's why we are not able to identify. So image is distorted. Okay, distorted. So image is distorted or not properly formed. Okay, and whenever we have any lesion in parieto-occipital region, it will lead to appreciative visual agnosia. Associative means unable to visually identify in absence of visual impairment, means there is no visual impairment, still we are not able to identify any object, that is called as associative visual agnosia, and this is because of lesion in this is because associative visual agnosia means there is no visual impairment. Okay, no visual impairment, and we can identify object by other sensory methods like touch, and we can check the texture, color, pattern, all those we can identify, but we cannot identify by visually. So this condition is called as associative visual agnosia. Okay, then this is mainly because of lesion in occipito-temporal junction, and which is mainly present in inferior temporal lobe. So here correct answer will be inferior temporal lobe. Okay, so simply agnosia, if it is apperceptive, then the problem with parieto-occipital. If it is associative, means no visual disturbance, still we cannot identify, but we can identify by the touch, texture and all those, then the lesion will be in inferior temporal lobe. Okay, same if you know prosopagnosia. Prosopagnosia means inability to visually identify faces. Prosopagnosia means inability to identify faces. Okay, achromatopsia and cortical blindness, these are mainly because of primary visual cortex problem, and we have one condition known as astereognosis. So before astereognosis, you need to know what is stereognosis. Stereognosis means you can identify object by form, nature, and but without looking at it, means you can identify by the touch, texture and all those, but if you are not able to identify this all, that condition is called as astereognosis. This is mainly because of superior parietal lobe problem. Okay, next is which of the following is a tributary of inferior vena cava. Okay, so here I have shown you all those tributaries of inferior vena cava. So inferior vena cava's direct tributaries, first one is right and left common iliac vein, then we will have medial sacral veins. Okay, then we have 4 pairs of lumbar veins, then right gonadal vein, right renal vein, left renal vein. Okay, and right suprarenal vein, and we have hepatic veins. Other than this, just below the diaphragm we have right and left inferior phrenic vein. Okay, so these are all the tributaries of inferior vena cava. So if I will come, then right and left common iliac vein, 4 pairs of lumbar veins, right gonadal veins, right and left renal vein, right suprarenal vein, then hepatic vein, and right and left inferior phrenic veins. Okay, so here correct answer will be left inferior phrenic vein. Why not right suprarenal vein? Why not left gonadal vein? Because these two are directly, they are draining into left renal vein, and then left renal vein is draining into IVC. So they are not the direct tributaries of IVC. Why not right ascending lumbar veins? Okay, so for that, why not right ascending lumbar vein? If you know right side, this right ascending lumbar vein along with subcostal vein, they form a azygous vein. So this is also not the tributary of inferior vena cava. On the left side, this left ascending lumbar vein along with subcostal vein, they are forming hemiazygous vein. Okay, so this is all about tributaries of inferior vena cava, how azygous vein is forming, how hemiazygous vein is forming. Okay, next question is 14th. In 14th, a 6-month-old baby was brought to casualty with seizures. The pediatrician tries to do CSF sampling. What are the structure punctured by pediatrician while piercing through the anterior fontanelle? Okay, this procedure is called as ventricular tapping. Okay, this procedure is called as ventricular tapping when we are inserting a needle through the anterior fontanelle and reaching to the subarachnoid space and collecting the CSF sampling. Okay, so since you know anterior fontanelle, until it is not closed, there is no bone. Okay, means there is not a proper bone. So what are the structure pierced from outside to inside? So first structure will be scalp. If you know what is scalp, S for skin, C for connective tissue, that superficial fascia of skull. Okay, A for aponeurosis or galea aponeurotica with occipitofrontalis muscle. L for loose areolar tissue, and P for pericranium. Okay, so we have reached till pericranium. After pericranium we have dura mater, and then we have arachnoid mater. After piercing arachnoid mater, we have subarachnoid space. In subarachnoid space we have CSF. So correct answer will be scalp, dura, and arachnoid. Scalp epicranium endocrine, no. Scalp synchondral membrane dura, no. Pericranium dura, no. So correct answer will be scalp, dura, and arachnoid. Okay, along with this you also have to remember layers puncture during lumbar puncture. Okay, that also you have to remember. 15 question, which of the following are branches of anterior division of internal iliac artery? Okay, so simply internal iliac artery is having two parts, anterior division and posterior division. I will suggest don't remember anterior division branches, just remember posterior division branches and you will solve all questions. So posterior division, first branch is superior gluteal artery. Second one is lateral sacral artery. Third one is iliolumbar artery. Okay, so these three are the only posterior division branches of internal iliac artery. Rest all will be anterior division branches of internal iliac artery. If you want to know all the branches of anterior division of internal iliac artery, then first is obturator. Okay, second is superior vesicle. Third is inferior vesicle. Fourth is inferior gluteal. Fifth is middle rectal. Sixth is vaginal, uterine and internal pudendal artery. Okay, so these are all the branches of anterior division of internal iliac artery. So here we are checking superior gluteal, not a branch. Inferior gluteal, yes. Superior vesical, yes. Middle rectal, yes. Inferior vesical, yes. Vaginal, yes. So only first is not the branch of anterior division of internal iliac artery, rest also correct answer will be C. Here also I have shown the diagram, you can check. Next question is, a surgeon performing a radical neck dissection starting at the anterior triangle, which of the following will not see dissect? So for this you need to remember triangles of neck. Okay, neck triangles are divided into two major parts, anterior triangles, posterior triangle. Okay, anterior triangle is having four subdivisions. First triangle is submental, just below the chin. Second, submandibular or submaxillary. Third one is muscular, and fourth one is carotid. Fourth one is carotid triangle. Okay, so these are the parts of anterior triangle. Posterior triangle again has divided into two, occipital and subclavian, two parts. Okay, so here you can check which is not correct. So submental is the anterior triangle, digastric is anterior triangle, submandibular or digastric. Okay, carotid triangle is the part, only the subclavian triangle is the posterior triangle part, so C will not dissect this subclavian triangle. Next question is, which of the following structure does not form both roof and content of posterior triangle? Okay, so for this you need to remember the boundaries of posterior triangle and content of posterior triangle. Okay, so to remember the posterior triangle boundaries, in the picture I will show you. This is the anterior boundary. Okay, so anterior boundary is mainly formed by the posterior border of sternocleidomastoid muscle. Posterior boundary is formed by the anterior border of trapezius muscle. Okay, and inferiorly it is mainly by the middle 1/3 of the clavicle, and roof is mainly formed by the superficial fascia, which is having internal jugular vein and posterior jugular vein, and also it is formed by investing layer of the fascia plus cutaneous nerve. So all those cutaneous nerve which are forming the roof of posterior triangle are great auricular nerve, lesser occipital nerve, supraclavicular nerve and transverse cutaneous nerve. So all these form the roof of posterior triangle. Okay, so here you can see supraclavicular, yes, it is forming roof. Lesser occipital, it is forming roof. Great auricular also. The suprascapular nerve, it is not forming roof, but it is present in it is the content, it is not forming roof, but it is the content of posterior triangle, mainly in the inferior part. Okay, so the correct answer will be suprascapular nerve. Next is, which of the following is true about deep cervical fascia? Okay, so just logically we will see this question. Investing layer covers parotid gland and submandibular, correct answer. Okay, so we have to find the true, so correct answer will be first one. Second one is peritracheal. We don't have any deep neck, deep fascia neck by the name of peritracheal. It is pretracheal. Okay, first of all. Second, pretracheal covers both thyroid and parotid gland. No, it is incorrect. Okay, pretracheal mainly covers the thyroid gland and forming the ligaments of thyroid gland. Okay, axillary sheath is formed by peritracheal. No. Okay, first of all we don't have any fascia named peritracheal, but this axillary sheath This axillary sheath is mainly formed by the prevertebral fascia. Okay. Last is investing layer forms the floor of posterior triangle. No, just now I told you it is not floor, it is the roof of posterior triangle. So correct answer will be investing layer of deep covers the parotid and submandibular glands. Okay. So this deep fascia of neck is divided into 6 parts, or we have 6 parts. We have investing layer, we have pretracheal layer, we have carotid sheath, we have prevertebral, buccopharyngeal and pharyngobasilar. All these you have to remember fully, like where they are covering, which part is forming roof of posterior triangle, which is forming floor of posterior triangle, what are their contents, from where they are extending, everything you have to remember. I have given you here the diagram of these fascias. Okay. Next question is, which ligament transmit the weight of upper limb to the axial skeleton? Okay. So upper limb of axial skeleton, weight transmission we have to check. So we will in from the upper limb, weight is transmitted to the coracoclavicular ligament, means it is transmitted to the clavicle. From clavicle we have to transmit this weight to the sternum. So there is costoclavicular ligament which is transmitting weight to the sternum and first rib. Okay. Or I can say to the axial skeleton we have to transfer. Okay. Then from manubrium sterni, we have to transmit weight to the clavicle. So we have sternoclavicular ligament, okay, which is transmitting weight to the clavicle. Okay. So this is the sequence. So we have coracoclavicular ligament, we have costoclavicular ligament, we have sternoclavicular ligament. So here costoclavicular is present, coracoclavicular is present and sternoclavicular is present. So correct answer will be 1, 3, 5 or A option. Next, a 18-year-old athlete diagnosed with an isolated avulsion fracture of lesser tubercle of humerus. Forceful contraction of which of the following muscle is fractured? For this you need to remember rotator cuff muscles. Rotator cuff is having 3 muscles. Mnemonic is SITS. S for supraspinatus, I for infraspinatus, T for teres minor and S for subscapularis. Okay. All these 3 above muscles are inserted on the greater tubercle. Only the subscapularis is inserted on the lesser tubercle. So if any forceful contraction of subscapularis is there, then there will be isolated fracture of lesser tubercle. So correct answer will be subscapularis. Next is, which of the following types of joint is incorrectly matched? Okay. So correct answer here will be sternoclavicular. Okay. Why sternoclavicular? Because this is not a hinge joint, this is a saddle joint. Okay. Acromioclavicular plain synovial joint, correct. Wrist joint is condyloid, correct. Intercarpal and midcarpal is plain synovial joint, is correct. Okay. So for the joints you need to remember they are mainly categorized into 3: synarthrosis, amphiarthrosis and diarthrosis. Okay. Synarthrosis means fibrous joint, no movement at all. Amphiarthrosis means slightly movable or very little. So these are cartilaginous joint. And diarthrosis means freely movable, which are our synovial joints. Okay. If you know in fibrous, we have examples like sutures, syndesmosis or gomphosis. These cartilaginous again divided into 2: primary cartilaginous, secondary cartilaginous. In primary cartilaginous we have first sternocostal joint, we have growth plate, we have costochondral joint and we have spheno-occipital joint. Secondary cartilaginous joints, we have pubic symphysis, we have G-sternal joint and we also have manubriosternal joint. Okay. For this diarthrosis or synovial, this synovial joints again divided into 7 classes, okay, based on their mobility. Highly mobile is ball and socket, less mobile is our plain synovial joint, okay. So if you know ball and socket, highly mobile, these are our shoulder joint, hip joint, stapedial joint, talocalcaneonavicular joint, saddle maleo-inguinal joint, calcaneocuboidal joint, first carpo metacarpal joint, sternoclavicular joint, okay, which is here the answer. Ellipsoid joint, this is upper S joint, atlanto-occipital joint, and wrist joint and knuckle joints. Condylar, this is our mainly the condyloid, this knee joint and TMJ, temporomandibular joint. Pivot, it is our mainly the no joint, this is atlanto-axial joint. Hinge joint are our wrist, ankle, elbow, all these are not wrist, ankle, elbow and interphalangeal joints are our hinge joint. Plain joint are all those which are very less mobile synovial joints. This is acromioclavicular, costotransverse, costovertebral, sternocostal, all those are our plain joints, okay. And one more thing you have to remember for wrist is more of ellipsoid joint. If you have answer as ellipsoid in option, first mark ellipsoid, if not then you can mark condyloid, okay. Both are correct for wrist joint, okay. Next question is, a 25-year-old man comes with sudden pain in the right shoulder, okay. He complains that he is not able to move his right arm. For evaluation, a diagnosis of shoulder dislocation was made. Which of the following statement is false for this joint? If you know shoulder joint, or it is also known as glenohumeral joint, it is most mobile joint of the body, okay, very unstable. If you know the ratio is 1:4, means glenoid cavity is 1 and the head of humerus is 4 times larger than the glenoid cavity, all those things, okay. So that's why it is very unstable. It is most frequently dislocated, okay, and more commonly in adults compared to children, and most common dislocation is anterior dislocation than posterior dislocation. So all these questions are about dislocation of shoulder joint. So now we will read all those statements. First is glenohumeral joint is most frequently dislocated joint of the body, correct answer. As mobility of the joint increases, stability also increases. How you can say that mobility is increasing, so stability is increasing? This is false statement. So the answer will be B. But the third statement is saying shoulder joint dislocated is rarely in children, correct, because it is more commonly dislocated in adults. Anterior dislocation is more common than posterior dislocation. This is also the correct. So correct answer will be, or the incorrect statement will be B. As mobility increases, stability should decrease, but here they have mentioned increases, means this is the answer. 23rd question, which of the following statement is true about iliopubic tract, okay. So if you know iliopubic tract, it is the thickening of transversalis fascia, okay. So it is the thickening of transversalis fascia. It is present posterior to inguinal ligament, or inguinal ligament is also called as Pauper's ligament. Next, it inserts, or it extends from anterior superior iliac spine superolaterally, okay. Next, attachment you have to remember, okay. Medially it is attached to pubic tubercle, just behind conjoint tendon, okay. And laterally it has no attachment, it is simply fan out with fascia transversalis or and fascia iliaca. Okay, so now we will read the option. It is thickening of lumbar fascia. No, this is not the correct answer. It is thickening of fascia transversalis. Anterior to pupate ligament. No, it is present posterior to pupate ligament. It inserts into pubic tubercle in front of conjoint tendon. No, it is behind the conjoint tendon. It fibers fans out laterally with fascia iliaca. Yes, it is the correct answer. So correct answer will be fibers fan out with fascia iliaca laterally and fascia transversalis. Next is 35-year-old primary gravida presented with non-engagement of fetal head. She is suspected to having cephalopelvic distortion at the level of inlet, which does not form the boundary of involved structure. So for this you need to remember pelvic inlet boundary and pelvic outlet boundaries. Okay, so boundaries of pelvic inlet will be anterior boundary of pelvic inlet will always be, this is pelvic inlet. So here you can see this is pubic symphysis. Okay, laterally if you know this area or this arcs, so this is arcuate line and pectineal line, or I can say pecten pubis is forming lateral boundary. Posteriorly you can see here this is sacrum, so sacral promontory is forming the boundary. Okay, so since they have asked about the inlet, so which of the following is not forming the boundary? Sacral promontory, yes, it is forming the posterior boundary. Pecten pubis, lateral boundary, and this pubic symphysis, anterior boundary. This ischial tuberosity is not forming any boundary, so this will be the correct answer. So where we have to say that ischial tuberosity is forming the boundary, so pelvic outlet boundaries also anteriorly pubic arch, okay, the arch part of pubis, laterally this ischial tuberosity, here you can see this ischial tuberosity and this sacrotuberous ligament, okay, inferior part of sacrotuberous ligament, and posteriorly tip of coccyx. They are forming the boundaries of pelvic outlet. So whenever in obs gynae you will read non-engagement of fetal head, okay, non-engagement at term, non-engagement at term plus and the patient is primary gravida. You have to have two differential diagnosis. First one is either it can be contracted pelvis or cephalopelvic disproportion, CPD. Okay, so this is about question number 24. Question number 25, which of the following structure of inguinal canal lies outside the internal spermatic fascia? So correct answer is ilioinguinal nerve, because it is the content of inguinal canal, okay, which is present just inferior to the spermatic cord, but this is not the content of spermatic cord, that's why it is present outside the internal spermatic fascia. Here I have given the content of spermatic cord, okay. So the correct answer will be ilioinguinal nerve, which is the part of inguinal canal but not the content of spermatic cord, so that's why it is present outside the internal spermatic fascia. Along with this you have to remember all the contents of inguinal canal, how these internal external spermatic fascias are forming, okay, all these you have to remember. 26th question, a patient present with tingling, numbness, burning pain outer side of the right thigh, but there is no motor dysfunction, means it is purely sensory dysfunction, which is the root value is affected, okay. So the correct answer is L2 L3. Why? Because posterior division of L2 L3, this is forming this L2 L3, this is forming the lateral cutaneous nerve of thigh, okay, or lateral femoral cutaneous nerve, because they have mentioned outer part, means it is the lateral part. So the correct answer will be B, L2 L3. All of the following ligaments are component of external laryngeal membrane except, okay. So for that you need to remember what are the external laryngeal membrane and ligaments, what are the internal laryngeal membranes and ligaments. For external laryngeal membrane and ligament you need to remember, first one is thyrohyoid. Second is hyoepiglottic. And third one is cricotracheal. Okay. Same for internal laryngeal. You need to remember, first one is quadrangular membrane, second is cricothyroid membrane and thyroepiglottic ligament. Okay, so we will check. They are asking all those for external laryngeal except means not for external laryngeal. Thyrohyoid, yes. Cricotracheal, yes. Hyoepiglottic, yes. Cricothyroid is the internal laryngeal membrane or ligament. Okay, so this is the correct answer. Next is, which of the following statement is true regarding the laryngeal cavity? For the laryngeal cavity, we have to check the correct. Okay, so if you know, larynx is divided into three parts: upper part, middle part and lower part. Upper part, supraglottic part or vestibule, middle part is the ventricle and lower part is infraglottic part. Upper part is between laryngeal inlet and vestibular folds. Okay, middle or ventricle is between vestibular folds and vocal folds, and lower part is between vocal folds and trachea. Okay, vocal folds or and cricoid cartilage, more specific. Okay, so here you can see in this diagram, this from the epiglottis till vestibular fold, this is upper part, this all area between this is our ventricle or middle part, and from here this low part is all our infraglottic part. Okay, now first they are asking, laryngeal ventricle is between laryngeal inlet and vestibular fold? No, because laryngeal ventricle means middle part is between vestibular fold and vocal fold, so this is incorrect. Vocal folds are lined by pseudo-stratified ciliated columnar epithelium? No. Okay, for the epithelium of larynx, you need to remember, all parts of larynx are lined by pseudo-stratified ciliated columnar epithelium, except three places where we need more, where we need a epithelium which is more sustainable or more, which can like resist more injuries, like vocal folds. It is not having this type of epithelium. Lingual side of or lingual surface of epiglottis and upper part of airy epiglottic folds. Okay, all these three are lined by non-keratinized stratified squamous epithelium. So second option is also incorrect. Third one is rima glottis is present between vocal folds. Okay, so here you can see we have two apertures. Okay, one aperture is here, one is here. Okay, the aperture between the vestibular fold is called as rima vestibuli. The aperture between the vocal folds is called as rima glottidis. So this will be the correct answer. Next option is ventricle is a pouch from the anterior end of saccule. It is incorrect because this is the ventricle and anteriorly extension of ventricle is called saccule. So the option is, if they have written saccule is a pouch from anterior end of ventricle, then it will be correct. If they have written the other way around, then it is the incorrect option. Okay. Next we will come to the 29 question. Which of the following prevents polyspermy? The correct answer is cortical reaction. Okay. So during this reaction, during the fertilization process, we have three reactions. One is acrosomal reaction, I am writing in sequence. Then we have cortical reaction, and in the last we have Jonah reaction. What is acrosomal reaction? When sperm acrosome react with ovum's layer and releases hydrolytic enzyme. Cortical reaction means when cortical granules are released and they will make some changes in the zona pellucida. And zona reaction means after penetration there is some changes. So why cortical reaction? Because it will prevent polyspermy. Okay. If they will ask you which are the two reaction which can prevent the polyspermy, then both will be correct answer. Okay. Last question is, which of the following structure develop from the sixth pharyngeal arch on the left side? So if they are asking left side, correct answer will be ductus arteriosus. Okay. So in the last this question you have to remember all the pharyngeal arch derivatives, okay, such as like in first pharyngeal arch you will have part of maxillary artery developing, from second pharyngeal arch stapedial artery is developing, from the third arch right and left common carotid, right and left internal carotid arteries are developing, fourth right subclavian artery and arc of aorta is developing, fifth is regressing in the humans, and sixth is right and left pulmonary arteries, along with on the left side ductus arteriosus is also developing. So correct answer will be ductus arteriosus. In the last, thank you very much. Here we have discussed all those 30 questions from the anatomy test of Mahotsav Scholarship 2.0. I hope you will find this useful, and stay tuned for the next test. Next test is pharmacology, and soon I will make video on pharmacology test discussion. If any doubt, please contact to WCIC OS team, and thank you very much.